Our third, our third TED Talk, Quality TED Talk, is titled Designing for High Reliability, Insights from the Don't Hesitate, Escalate campaign. This talk will be presented by Dr. Ann Watson and Heather Walsh. Dr. Ann Watson is a research nurse coordinator in critical care medicine. She obtained a PhD in developmental psychology at the University of Michigan in 1990, and then did a postdoctoral fellowship at the National Institute of Child Health and Human Development. After the postdoc, she was an assistant professor, first at West Virginia University and then at Illinois Wesleyan University. Her research interests and teaching responsibilities included the areas of early social cognition, play, infant learning, infant attachment, human development, prenatal and infant development, language acquisition, cognitive psychology, and research methods. Dr. Watson then pursued a one-year accelerated second-degree BSN program at Duquesne University. After 5 years working as a registered nurse in the neonatal and pediatric intensive care unit and follow-up care, she came to Children's National as a research nurse coordinator for critical care medicine. She manages several databases for the department as well as working on multiple research and quality improvement initiatives for the hospital. Heather Walsh is the outreach coordinator for the simulation program here at Children's National. Heather received her Master's of Science in Nursing degree from George Mason University and is certified as a pediatric nurse, a pediatric clinical nurse specialist, and a healthcare simulation educator. Heather was fortunate to complete the Master Teachers Program at George Washington University in 2008, where she initially became interested in interprofessional education. She is the first nurse member of the Children's Academy of Pediatric Educators, better known as CAPE, a network of master teacher alumni engaged in education research. Heather completed the National League of Nursing Leadership Development Program for Simulation Educators in February. Her research includes a pediatric early warning score, workflow qualitative study on nurse shadowing, and a multi-site simulation study validating a SBAR tool. In simulation, Heather has observed the moments when learning has occurred across disciplines and hopes to expand the interprofessional simulation across the organization to improve teamwork, communication, and escalation of deteriorating patients. Please join me in welcoming Dr. Ann Watson and Heather Walsh.
Yes, thanks, Janice, and everybody for having us here today. Heather and I are also going to be talking about some of the work that we've done around patient deterioration on the acute care floors. Prior to the collaborative that was developed, Heather and I both had the opportunity to work with a great team on the Don't Hesitate, Escalate campaign, which I'm sure most of you are familiar with. As we have discovered over the long period of time that we've all been working on this, the numbers of people that have been working in this area, it's pretty hard to make performance improvement gains. And what we're going to talk about today a little bit is some of the human factors research that and teamwork work that we've been doing. Development of complex procedures and these education bursts, and then sort of doing the performance assessments are critical, of course, but are sort of one stepping point towards really the creation of what we call these high reliability organizations. As you just heard, I'm a psychologist and have a lot of background in behavior analysis and cognitive science. And it's been really exciting for me to see sort of medicine beginning to embrace a lot of the concepts from these areas, just as we all know other industries have done. One critical component of this this kind of a perspective is that we have to always keep in mind that to avoid an extreme dependence on hard work and vigilance as the source of change, which I think we still have a lot of growing to do around here at Children's National. It's very important to the creation of a high reliability organization to understand that nobody comes to work planning to make errors, to be sloppy, to be difficult, to be lazy. We really cannot have this idea about workers and create healthy and productive work environments, not to mention ethical and just ones. We need a clearly established culture of justice and not blame that is communicated throughout all levels of the institution. In other words, systems generate errors, not individuals. We need to, in taking a human factors approach, we need to be always paying attention to the physical environment, including equipment and technology, and our organizational structure, in addition to how humans are built, how humans perceive, how humans think, which is not always logically the fact that human beings are under stress or may perform differently under stress and in different conditions. And the organizational structure really involves the social environment too. So Heather and I worked with this wonderful group of individuals to do a project that looked at the workflow around data collection and charting, or collection of the information needed to chart the pews. We know that RNs are working under extreme time pressure. They need to multitask. There's all this increasing technological complexity, and we thought that examination of nursing workflow around pews was very similar to a lot of the activities that have been looked at in terms of med administration along these same lines. So we did some behavioral observations on the acute care unit. We also did focus groups and got feedback from the nurses who were using the pews. And we did observations of behavior through a chart review, which was different from an audit in that we looked at the timing of data of charting of vital signs and the Pews score, as well as the consistency between the charted vital signs and the Pews score. So in Cerner, you're able to look at the time of documentation of anything that you put in there, so that we know when the data or the element is put in. So we compared the time of documentation of Pew scores and compared those to the scores to vital signs that were closest to the Pew's documentation. What we found from our direct observations was that monitors were used to collect physical assessment information in 13 of the 15 observations. So a hands-on assessment at the bedside was not obviously done. All but one of the RNs used a paper brain to document the information that she was then going to enter into the chart. And bedside documentation in the EMR occurred in only 91 of the 611 observed 30-second units of charting time, only 14%. So most nurses were documenting later at the nursing station. During our focus groups, nurses said that they were more likely to postpone entry of Pews for patients perceived as stable. They stated that, which again, when we talked to nurses about this, that made a lot of, that it was not a silly thing to do. That makes sense in terms of if you've got a lot on your plate, you're going to figure out ways to organize what you do and in terms of how you think you're going to be delivering safe care. They stated that concurrent charting of patient assessments were emphasized more for PCTs than for RNs, so that there hadn't been an institutional sort of initiative about how the importance of concurrent charting. and that there were barriers, of course, to concurrent charting in the fact that the Cerner is so hard to access, the login times. And they said that they actually said that they didn't reference PCT vital signs when they were doing the pews. From our chart reviews, which we actually were able to do before and after that Don't Hesitate, Escalate campaign, we confirmed what the nurses said in that there were significant issues with non-concurrent charting and vital sign charting mismatches. So we found that the nurses versus the PCTs were much less timely in their charting of vital signs. Okay, so this isn't even the Pew score. This is nurses' charting of any of the vital signs that they take if the PCT hasn't taken the vital signs. That there were significant delays in the charting of the Pew score, and only nurses are charting the Pew score, right? The PCTs collect the vital signs. Nurses are doing an independent assessment that they're going to use to chart the Pews. And we actually found an increase in delay in charting of the Pews after our campaign. We did see some improvement in consistency of Pews and vital signs post-campaign for heart rate assessment. So that's consistency between what the nurse had charted for a given time and what the PCT had charted for the given time. But the percentage of elevated vital signs with the Pews that is consistent with those vital signs, and the higher scores are the ones that we want, that we need to be more, well, higher ones are more worrisome, although they all need to be accurate, that continued to remain very low. So to summarize what our results were, we found all of these workarounds in terms of the electronic medical record, charting documentation. We discovered RN judgments about task priority that we actually thought were pretty good, and that we don't really, we want to know about that, and we want to have the nurse's involvement in terms of thinking about getting around those. And then, of course, we found this mismatch between staff responsibilities for overlapping aspects of detection of patient deterioration, that vital sign component. And again, we're not the only, we're sure that these findings, this is not just our institution, that this is going to be true of a lot of institutions around the country, and are the kinds of things that we're going to need to really take into consideration when trying to design high reliability organizations. When we've been presenting some of this work around the country, there are actually a fair number of hospitals now that are having nurses going back to taking the vital signs, because they're such an important component of that patient assessment. It needs to be done at the bedside. We need the nurses at the bedside more, and you know, that would be sort of one example of a system design change that would begin to solve some of these issues. Heather.
So I'm going to talk a little bit about the teamwork and communication and how this all kind of relates in terms of escalation, Pews, and patient safety. So as Anne mentioned, the high reliable organizations follow communication norms, and their employees use structured, adopted communication tools. So, you know, we have SBAR, we have handoff, we have peer coaching and peer checking, but do we all know what it means? I mean, we've learned it, but are we actually using it in practice? You know, patients are sick, there's lots of tasks to do, people are really busy. You know, we're about to get another group of 40 new physician interns. You know, we have a revolving door of new nurses coming in the hospital. And so many of our units have a large percentage of new grads. So that, you know, we have people who have been here a long time, and then we have increasing numbers of new nurses with less than 3 years of experience in all of our units. So I'm just going to talk about a few projects that I'm involved in and kind of what we've found. The first is in terms of improving communication nurse shadowing. So this is something that started back in 2011 when I was still an educator on 7 East. But I just wanted to highlight, this is a quote that one of the nurses said when we went back and did a qualitative study. So basically, the residents started shadowing a nurse. They spent a few hours. The first several of them liked it so much that it was embedded in the resident curriculum in 2012. And so every year, essentially, all of the pediatric residents are spending 4 hours with a nurse on 7 East learning the workflow. It was thought that they would kind of achieve a shared understanding and improve teamwork if they could talk about communication barriers and strategies to overcome them. Let's see. So an interesting finding in the name of the paper that we actually wrote about this study was from the other side of the computer. And so this is something that I hadn't really given much thought to, but because of all the technology, the nurse will text page to the physician rates the order, but they might not even know each other face-to-face. They have very limited face-to-face interactions on rounds, and that might only be one time a day, and you're taking care of the patient for the whole day, and really just don't have the face-to-face interactions that we used to have when we did paper charting and people would chart next to each other, and the doc would put in the order and tell the nurse, by the way, I just ordered this. And so there have been a lot of a lack in communication and teamwork just because people don't know each other. And this was one of the quotes from the resident. I mean, we're people too, we're not just the other end of the computer. And really understanding that we're both busy and we're both doing things, but understanding what those things are. A second project is as a part of a hospital-wide sepsis initiative, which is coming soon to a unit near you. We decided to do some focus groups to serve as a needs assessment, and we met with nurses on 7 East, 4 East in the ED. We met with hospitalists, residents, and then a provider group on HEMOC. We have three questions. How do you identify a sick kiddo? How do you escalate? And then have you ever felt you needed to escalate but didn't? And if so, like, what were those barriers? And so while the Don't Hesitate, Escalate campaign happened a few years ago, it became quickly apparent that many barriers still exist to escalating patients' deterioration. So this is something that an inpatient unit nurse said, that she, that it's not anything personal. It's not that they don't trust them, but they're calling a CAT. And that's what they're supposed to do if they need help within 15 minutes. And so then, you feel bad for the nurse, like, yes, I get it. She needs help. She's making one phone call. The CAT team's going to come. They're going to help her out. But from the resident's perspective, they say there's nothing worse than taking care of that patient. You're the first person arriving to the CAT, but you really don't even know why the CAT was called because you weren't aware of the nurse's concerns. And so just really understanding how we can work together to communicate our patient concerns so that the whole team is involved. And most importantly, that the patient gets what they need in a timely manner. I want to show a little clip from a live serious safety event that we did last March in this very room. This video continues to be used with our nurse residents to role model positive behaviors, communication, and caring for deteriorating patients and their families. So I think a lot of times we tell people what they're supposed to do, but we don't really show them what it looks like, and so that's what this video shows. It was based on a real case that happened here. The first clip you'll see is where the CAT team is basically appearing in the patient's room. And though the communication you'll witness is not what we had hoped for, the audience participants agreed that this is sometimes how things happen during a CAT. I promise I'm not showing you a 25-minute clip. All right. We are going to 13 minutes, right when the CAT team comes in.
They didn't find like nothing significant on examination of right now. I think we have some vitals too.
Yeah, let's get
I'm Anna.
Right. Oh, there he called you guys. Yeah, this is a kiddo. I mean, we just got him on the floor, but he's a 5. He's vomiting bilious.
Yeah, this
we
kid is.
thought he was asthmatic, but
Yeah, he's clearly septic. We're just gonna take it
anybody want to order it?
We'll get reported.
You know what time the bed's gonna be ready?
I've already made the phone call.
Okay, so they're basically just swooping up the kid and saying, he's clearly septic, which leaves the team feeling like they missed the boat on something, he's really sick, you did something wrong, so the team members will feel bad. The parents are confused, like, what's going on? Nobody's even talking to me. I'm not sure, did the team mess up and now you're coming in to save the day? And it's really a missed opportunity for both teams, the floor team and the ICU team, to have a shared mental model and really understand what happened. So really there's no learning for the team on the floor unless people go back afterwards to say, here's what I think happened, and in the future, these would be opportunities when you see a patient similar to this. So we ran the escalation a second time, which I will now show you. This is, again, the role modeling of kind of the right way to do things.
So we can go ahead and start the vote as well as before him. Yeah, so 20 cc's per kilo, which will be 500 ml for. Do you need any help?
Hold on, I'm going to get some more information from Dr. Halga, but we're going to stay here with you. We're not really going to leave. We're going to be here with him because we're definitely concerned, and we may even be getting a few more people involved here shortly. But we're going to ask you some more questions, okay? In just a minute, but we're just going to talk for a moment, okay?
Thank you. And we you're comfortable, if your saturation is okay,
Yeah, and you guys
still
are
have
going
room
to write this and put it in the
Yeah, we'll definitely put it in the watcher note, and we can actually discuss what our goals are right now, what we want to do, and, you know.
Yeah, he's not looking so high.
Okay.
Right. Yeah.
Okay. So I think what Julie and I were just talking about, we are gonna put in our watcher note right now.
We're gonna, take close attention to him. He's, borderline where we're pretty concerned, and as are you, and we want to document that, put some goals in mind, and develop a plan of what's going to happen if, he doesn't turn around and if our interventions, like we're going to give him a lot of fluid and see if that helps. Let me grab these issues. Okay.
So let's give him a ball.
Yeah, so we have a little plan.
Okay. Oh, let's see now. Okay. Sorry, lots of back and forth with this. Okay, so what I wanted to highlight about the second clip is that the charge nurse was supporting the bedside nurse. So she was able to be there to help hang the bolus and help actually with the physical care, but also making sure that the bedside nurse felt supported. She talked to the mother, and I love the way that she used touch. She was really addressing the mother's concerns and explaining what was going to happen. She offered her tissues. And then the intern had called her senior resident. So I like that there's the parallel, that the nurse and the charge nurse, the resident and the senior, and they're all kind of talking together. So they're talking in their little sidebar, but they're also kind of talking across at each other as well. And I think they had achieved a shared mental model, and they also included the mother. So they agreed that they were going to start some things, but then also call the ICU. So how do we improve communication? That's like the $1,000,000 question. So shadowing another provider really helps people to gain an understanding of the nursing role, and that was what I consider a low-cost, high-impact strategy. It actually improved the residents that we interviewed. Some of them were one of them was a chief resident, and she had shadowed us her first year. So really, 3 years later, she really remembered in very good detail the nurse she had worked with and specific things that the nurse had taught her. The residents had changed their practice based on working with the nurse. So they would actually consider what the order would look like to the nurse on the other end before they clicked submit. And so that was really nice because I don't think they had thought of that beforehand. Scripting has worked in many industries and can provide nurses and other staff members with a template for what to say and how to say it, which as our system has gotten much larger, would really provide a consistent experience for our families. So when they go to the CPNA practice and then they're admitted here, or they're talking to any of our providers, that they do feel like it's one hospital and we kind of work the same way. Think of like Chick-fil-A. You know, you have like a 16-year-old handing you your chicken tenders and he's like, my pleasure. And the way that they always provide excellent customer service, and we should be doing the same here. Scripting really helps with that. Also, accountability, holding each other accountable, the peer coaching, so really reinforcing the expected service and safety behaviors to improve communication and teamwork. So speaking of improving teamwork, as we talked in our focus groups, a lot of the nurses told us that the large units like 7 East and 4 East, you could look down the hallway and not see anybody. So it really does create a sense of isolation for the staff. When they kind of look around, they don't see anybody, so then it's like, well, who's going to help me? I have a sick patient I'm worried about, and now I have to go look for somebody instead of somebody saying like, Amber, I haven't seen you all day. Are you busy? Like, how can I help you? When we had the smaller units, it was a lot easier to do that. Now you could work on a unit and not even know everybody that you're working with for that day. And so I think the technology challenges have also further impacted the relationships between nurses and then also with the residents, like I mentioned. On some units, the residents have actually done structured night rounds with the nurses, and the nurses really appreciate that because they feel like the concerns are addressed. It's not the answer that they get isn't let's wait till rounds in the morning, but that things are actually addressed and there's a plan in place, and that having that face-to-face time, they're able to kind of nip any problems in the bud rather than waiting till the morning when they get worse. But I like this little thing. How can they work together if they don't learn together? And that's a big thing that I would like to see us do here is learning together. And then how do we improve teamwork? So in my role as the simulation outreach coordinator, I work with Pam Kine a lot, who's in the audience, and we go visit the ambulatory sites. It's not just for the nurses, it's not just for doctors, but we really like the whole team to get engaged. And then we've actually had real events. We've heard stories of the corps, who are the secretaries out in the rock locations, actually standing outside of the building waiting for EMS if they've had to call 911, that they're actually standing there waiting to take EMS to the correct location to find the patient really quickly. And so we really highlight that everybody's job is really important. We are doing an IS-bar simulation, so as part of the sim leader program I just finished, we're putting the new nurses through a simulation where we're actually having them call S-bar to the physicians, and we're giving them feedback on some opportunities for improvement. A lot of the nurses are really making the connections of the patients having shortness of breath and leg pain. I think they're having a DVT, but when they call the doctor, they say, can you come please assess this patient? And so I'm really encouraging them to say, I think the patient might have a clot because of this, this, and this. Can you please assess? Because it really does make a stronger case. And then when the team comes, they know what the nurse is thinking. And then in the debriefing, we really encourage everybody to identify opportunities for improvement. So how can we improve teamwork and communication? What are strategies that we can use? So we're not lecturing them, but we're really asking people to reflect on how could we do this better next time. So thank you for having us present. Oh.